All right. So I was asked to make sure that everybody was aware that today is the last grand rounds of this academic year. We will have a break for about 3 months and start up again in September. So Dr. Taylor has the distinct pleasure of being the last person to present grand rounds this year. I feel lucky to have the opportunity to introduce you to Dr. Taylor. I'll tell you a little bit about her background first. She graduated from medical school at the Kansas City University of Medicine and Biosciences in Kansas City. What many of you may not know is that she also received her MBA at the same time, and kind of specialized in the area of healthcare leadership, which I think parlays into this topic today quite nicely. She then has joined our residency program, is currently a chief resident, and stayed around for her 4th year to actually do a number of the electives that she's interested in, despite the fact that she's been interested in child and adolescent psychiatry since she got here. So unlike most people, she actually stuck around for an additional year to do a number of the electives, which I think speaks a lot about her and her desire to kind of expand her horizons and further education. We've been lucky to have her, and after this she is moving on to her Child and Adolescent Fellowship at Yale. So we certainly wish her the best of luck. Dr. Taylor has nothing to disclose, and we are very fortunate to have her here today to be presenting. I don't have the actual topic. I don't have a... So that way I can announce it to the masses.
The U.S. healthcare crisis and what we can learn from the single-payer system.
Okay. So she's pulling it up here for me because I couldn't remember what it was. Here we go. Oh, yes. Look at that. Very patriotic. Dr. Taylor's talk is the U.S. healthcare crisis. What can we learn from a single-payer system? Please welcome Dr. Taylor.
Thanks so much for everyone for coming today. I greatly appreciate it. And I'll be honest, I am kind of anxious being up here, but lots of people have asked me about that, and I just figure it can't be as bad as when I gave this talk in Spanish, so let's hope, right? So like Dr. Heron said, my name is Lane Taylor, and I'll be talking about the healthcare systems both of the United States as well as of Spain. I was fortunate enough to be able to do a 2-month rotation in which I worked in several medical centers in Pamplona, Spain. And I got to observe the healthcare system there. And I'm going to talk to you a little bit about what I've learned. Okay, so let's just go over the goals of this presentation first. I'm going to do a quick overview of the U.S. health system. Many of the folks that are here today are already familiar with the U.S. health system, but I definitely think it's important to review it so that we can have a good comparison of the two. I'll use Arizona as an example of that system. Next, I'm going to do a description or explain the system that they have in Spain. And I'll use the province of Navarra, which is the province where Pamplona is. Then I will discuss how much healthcare costs in each country. And one of the things I'll talk about is the salaries of mental health professionals there along with taxes and lots of different things that make up expenditures for health. Then we'll be discussing the problems of each system. So I'm trying to be very unbiased here and just present to you, and I'd like to get a good conversation at the end based on what the information I presented. Finally, we'll look at cultural impacts. I firmly believe that the culture of each country really impacts healthcare, the healthcare systems, and how healthcare is delivered. So we'll be reviewing that. All right, so let's start. We're going to start by talking a little bit about the U.S. healthcare system. So here we have public and private systems. We also spend a lot of money for our public and our private systems. Just very quickly, and we'll talk more about expenditures later, but for Medicare in 2007, we spent $431 billion, and for Medicaid, we spent $329 billion. Private health expenditures of the government and individuals totaled $1.2 trillion in 2007. So we spent a lot of money on it. So I don't want to inundate you with numbers, but when you're talking about health systems and economics, there are a lot of numbers. But just a few more. In 2007, it was determined that $7,421 was spent on each person for health care in the United States. And that accounted for 16.2% of the U.S. gross domestic product. So we spent a lot per person in that year. In addition, over 45 million patients were enrolled in Medicare in 2007. And just in Arizona, Medicaid enrolled just under 2 million people. And that number is as of April 2009. So a lot of folks. So now we'll take a look at private insurers, because that's a big, big portion of our system here in the U.S. So just a few examples of the private insurance. There's several different types, but a few examples are preferred provider organizations, health maintenance organizations, health savings accounts. And these companies determine what type of services are to be covered in each program, and each plan is highly variable. They can also determine whether or not they're going to pay for a particular treatment. So certain plans may cover mental health, certain plans may not. Certain plans may not cover prescriptions. So these insurance companies can decide whether or not to pay. It doesn't mean that the person can't get the treatments, it just means that the insurance company may not pay. In addition to that, the healthcare insurance companies can, say, deny people admission into the insurance because they're too high of a risk, because of, as we know, pre-existing conditions, right? Diabetes, maybe there's a history of cancer, things like that. They can actually say, sorry, you're too high of a risk, I'm not going to be taking you into my company. All of that being said, the reality is that private insurance is the main form of insurance here in the U.S., and the majority of physicians see patients with private insurance. So our public health care system, quick overview, there are three main parts to it. We have Medicare, Medicaid, and the Veterans Administration. Medicare and Medicaid are together, and they are under the Centers for Medicare and Medicaid Services, which is a part of the Federal Agency of Health and Human Services. So those areas decide funding and services, all of that. The Veterans Association is separate from that and is under the Department of Veterans Affairs in our national government. So all three are actually funded at least in part by the federal government. However, Medicaid also receives funds from the state government. And this means that the services provided in each state under Medicaid is highly variable from place to place. An example of that are actually services for children. Every state covers services for children, but each state determines how much is actually covered, what income level is covered, and that's highly variable from state to state. Okay, so the VA, just a quick word on the VA. There's a quote upon which the VA was started. I think it's actually pretty nice. It is said by President Abraham Lincoln, "To care for him who shall have borne the battle, and for his widow and his orphan." Well, President Lincoln did not start the Veterans Administration. It's a little bit younger than that. It started in 1930 by President Herbert Hoover, and the main goal is to provide health care for the veterans, their widows, and their orphans. There's a veterans hospital in every state, and they not only provide medical care, but social services are also provided. So, for instance, our VA hospital here in Tucson provides treatments or financial services for the homeless, different things like that. And again, the Veterans Association is self-contained. It is actually the closest thing we have in the U.S. to what might be a universal healthcare system. And its network structure is very different from that of Medicare and Medicaid. So Medicare. Medicare is also pretty young. It started in 1965 by President Nixon. And it is solely for the treatment, providing health care for the elderly, those with disabilities, and those and orphans, people without parents. So within Medicare, these groups of people have full coverage with a copay and some deductibles, and we'll talk a little bit about how that works. But this coverage also includes psychiatric services. In 2000, President George W. Bush incorporated a prescription coverage under Medicare. But until then, prescriptions were not covered. All right. I'm not quite sure how the elderly navigate the Medicare system. It's incredibly complicated. As I was researching it, trying to boil it down to some real general terms was actually pretty difficult, but I'm going to give it a shot here. There are two parts to Medicare, if you don't include the prescription plan, which is actually even more complicated. You have Part A, which includes inpatient services like nursing, meals, room costs, lab tests, and supplies. And then you have Part B, which cover physician services for both inpatient and outpatient, and also cover outpatient visits. For mental health, this means that group and individual therapy is covered, occupational therapy, neuropsychiatric testing is covered, and another really interesting is non-self-administered medications are covered. So an example of this is if you have a patient that requires every month Haldol depot shots, Medicare Part B would cover that medication, but not their regular Haldol everyday pills that they take themselves. And Medicare has copays. And again, this gets really, really muddy. So just making it as clear as possible. Part A, there's a deductible of over $1,000 for a hospital stay that's less than 60 days. As you stay longer, you have to pay more. And there's also a monthly premium of $96.40 every month that you have to pay regardless of the fact that you're in the hospital or not. Medicare Part B has a deductible of $135. Okay, so Medicaid. Medicaid is not relegated to any particular demographic. It is actually based on income. And an example of this is if you're in Arizona and you're a single male, the income level you must have is you have to make less than $903 per month to qualify. And to just kind of give a different perspective on it, that is actually less than $12,000 a year. It's not much money at all. So if you have more than that per month, you're not able to receive Medicaid. Again, Medicaid is funded by both the state and the federal governments, and there's high variability. Okay, so a little discussion on mental health coverage with Medicaid, and again, that is variable by each state. So we're just going to focus on Arizona here. Arizona in particular divides its Medicaid into different umbrella agencies. And so each county has a different umbrella agency. Here in Pima County is the example I'm going to use. We have Community Partnership of Southern Arizona, or as we all know it as CPSA. So under CPSA, there are, within Pima County, there are 4 agencies: SAMHEC, Kodak, COPE, and La Frontera. SAMHEC is a little different from the rest in that it's basically urgent care. A patient is seen there and treated until they're able to be placed into one of the other 3 agencies. And each agency is kind of known to be particularly good at one thing, but they cover all services. So an example is Kodak kind of has the fame of being good for addictions, but everything is covered. You know, they deal with all different types of mental illnesses within each of those agencies. Okay, quick overview of the U.S. We understand a little bit more about the system. Now let's take a look at the health system of Spain so that we can try to do our comparison. So in Spain, all citizens are covered by what they call Social Security, or Seguridad Social. And this means that health service coverage is free for citizens. Example, you get into an accident, you go into the ER, you get patched up, you get all the treatments you need and the imaging you need in the emergency room. As soon as you're ready to walk out of there, you walk out of there, you don't pay anything. Conversely, though, immigrants, it's a little more difficult for them to receive the kind of health care that a Spanish citizen might get. They can receive Social Security, they definitely can, but they have to receive resident status from their job if they're working in Spain, or they have to get, there are other federal requirements that have to be met. So there's individual approval. Each person has to be approved by the federal government to determine whether or not they should be able to receive Social Security. It should be known that just like here in the U.S., if you're an immigrant, you go into the ER, you require treatment, you get treated and you don't have to pay. However, you can't get ongoing treatment under the Social Security services if you're not a resident or you're not already approved. Conversely, here in the U.S., an important thing to note is that especially in Arizona, if you don't have your birth certificate, if you have not been documented to be a citizen of the U.S., you cannot get enrolled under Medicaid. You can get emergency treatments. They'll charge you. Whether or not you pay is another question. But you can get emergency treatments, but you will not be able to get covered under Medicaid. Okay. So, the health system of Spain was initially a centralized system, but in 1981 they changed to 17 autonomous communities. And this process took them a long time. So to switch from where the federal government took everything, it took them 20 years to get to the point where every autonomous community was set up. Long time. And all of them have the same taxation system. And we'll talk about the taxation system and how they pay for Social Security in just a second, with exception for the Basque Country and the state of Navarra. And we'll talk a little bit about why those are different at the end of the talk. So VAT, or value-added tax, which is basically like their sales tax, income tax, vendor privilege tax, and a few other smaller taxes go towards the Social Security funding. Okay. So, in addition to the public system, Spain also has private health insurance. And 12.6% of the Spanish population actually also has private health insurance. Even more interesting to me is that 50% of civil servants, which includes people that work in healthcare, have private insurance as well. So psychiatrists, physicians, nurses, garbage men, 50% of those folks actually get their own private insurance. We'll talk about when we get to the problems, it'll make a lot more sense why they would do that. But what this does, the private insurance, is it provides faster service, and it actually covers certain aspects that are not covered under Social Security, such as dentistry. There's always a joke about, you know, the British and their bad teeth. Well, that's actually because dentistry is not covered by the social health care system. Spain's the same way, though their teeth are a little bit better. So, know what you make of that. So, how do you get private health insurance in Spain? You can buy it as an individual. Your employer can pay for it like they do here. Or you can be a part of a corporation that actually has their own individual healthcare system where you don't have actually private insurance, but the corporation has its own like clinic and urgent care, and employees are able to receive treatment there. It's actually something they had during the Industrial Revolution in the US when we had much larger corporations. That's no longer the case. So let's look at mental health in Spain. So mental health is actually a part of the general health system. So it's not a separate section or anything like that. And that's important to know, and I'll talk to you about that in a second. As it is known today, as the mental health system is known today in Spain, it began in 1986. Not that there wasn't mental health before 1986, but as it's seen today. The way that you enter the mental health system in Spain is you first have to be seen by your family practitioner or your general practitioner. You go to them and you say, you know, I'm pretty depressed. Talk to them about your problems with sleeping, your depressed mood, go through all the SIGI caps because it's a really good family practitioner. And they try to treat it themselves. They try to treat some simple depression themselves, sometimes bipolar disorder, sometimes schizophrenia themselves. If it becomes too much for them to handle, that's when they refer out to a psychiatrist. So, under the mental health system or the general health system, You can receive treatment by a psychiatrist, a psychologist, a social worker, and even a nurse that specializes in mental health. What is not covered is psychoanalysis and hypnosis. That is very clear. They will not cover those things. And it's also important to know that therapy is a little different there. Psychiatrists don't do therapy in Spain. Therapy mainly in the public system serves a maintenance role. So if you have a patient that's particularly sick, but the physician's next appointment isn't for 2 months down the road, you have a social worker, a psychologist, or a nurse that will see this patient every week in order to make sure that they're not going to kill themselves, that they're somewhat stable if they have psychosis, things like that. And if there's something wrong in between then that social worker can talk to the physician about making an urgent appointment for the patient. Okay. Another important thing to know about the mental health system in Spain is that back in the late 70s, there was a push to move mental health to the community, just as there was here in the U.S. And they actually got rid of the vast majority of hospital beds for psychiatric patients in Spain. Well, quickly they learned that there are patients that are just so sick that they need to have hospitalization. And they had to start creating more and more beds, more and more hospitals. So there are actually quite a few acute mental health or psychiatric hospital beds in Spain. The longer term or residential level, it's a very small number. But they also have an intermediate day hospital, which is a fascinating thing to experience and see. So if you're a person that's suicidal, you can certainly walk into the ER and be placed into a psychiatric hospital. You can also go to your general practitioner or to your psychiatrist and be placed into a psychiatric hospital. Okay, so just kind of looking at how funds are distributed to mental health. Well, all of the ACs, or the autonomous communities, determine how much they're going to give towards mental health services in that province, pretty much. And for that reason, it is really variable on whether, how many mental health services are available to the citizens by province. And also, an important thing to know is that the state or the province where I was, Navarra, as well as Catalonia, where Barcelona is, they're particularly well known to have really phenomenal mental health services. Navarra itself is pretty tax-rich, and so they actually have more money in general, and they appropriate more money towards mental health. So in both the public and the private hospitals where I was, we had patients from all over the country that would travel, from as far south as, Valencia, in order to come and receive mental health treatment because of the differences between the states or provinces. Separate from mental health and separate from the general health umbrella is social services. And they have grouped addictions, treatment for the elderly, those with developmental disabilities, into the social service sort of category. So the funds are appropriated differently, taxation is different for that area, and it varies per province. And so depending on where you are, you could actually not have very much money appropriated to social services section, or you could have a lot. All right, so we've talked about both systems. We know how they're all structured. It's probably as clear as mud at this point. But now let's just take a little look at how much health costs in each of these countries. I think it's really important to first understand the wealth of each country before we start talking about expenditures. And so I'm supposed to use this pointer here. So what you can see here for 2005 and 2006, there is a difference. This is the gross national income per person. This isn't just the average income of the individuals in each country. This is if the government took all their money and decided to just pass it out to everybody, how much would each person in the country get? And you can see it's higher in the U.S., not a whole lot, but it's higher in the U.S. And we are talking about, 50,000 is the first line here. But then if you look at the population is far greater in the U.S. And that's just an indicator of how much more money our government has than in Spain. We also have more people. Okay. This next slide here is really important to take a look at as well. This first portion here is how much each government spends on health as compared to what the whole country spends on health. So the government of Spain actually spends 72.5% on health. So spends more. The government spends more than in the U.S. However, if you look down here at the very end here, you'll see that of total health expenditure in each country, 54.2% is the percentage of private expenditure in the United States. So it's higher. We spend more money on private health insurance. Next, we look at this section here. And here it's of private expenditures on health, the Spanish citizens spend more out of pocket for private health insurance at 76.4% of the total private expenditure on health. So that makes sense, right? I mean, they have their own government that's the public system. The federal government doesn't pay much towards the private insurances. But this here is the clincher. It's the smallest on there, but it's really, really important to take a look at. Of the total national expenditures of each government, so everything that's paid for by each government, you can see that the U.S. actually spends more on health, a greater percentage on health at 19.1% without having a universal health care system. Okay. And finally, this just looks at how much per person does the government spend. And here, clearly, the U.S. spends much more on health per person. However, in total expenditure on health of the people, of the corporations, of the government, the U.S. spends far more than Spain does per person on health. Finally, taxes. And here's where I want to kind of take a poll and find out any votes for whether they think taxes are higher in the U.S.? Raise your hand. Anyone? Higher in the U.S.? What about in Spain? Taxes are higher in Spain. All right. You guys are so smart. The reality is, yes, it is higher in Spain. They have a graduated tax system, and the range, so that what that means, graduated tax system, is as you make more money, the more taxes you pay. The range is 24% to 43%. In the U.S., it's also graduated, and the range is 10% to 35%. So all those numbers, all the stuff we talked about, we now know, I guess the bottom line is that healthcare is more expensive in the U.S. Why? Why is it? Well, honestly, it's impossible to explain all of that in the limitations of this talk. And honestly, I think it's probably not something we can answer at all, because I'd like to hope if we really knew why it costs more and why things were working the way they were, we'd do something about it. But the goal of this is to try to get as close to it as we can, try to figure out what's really going on in our system. So I'd like to look at salaries first. And again, I want to take a poll here. This is salaries in each country. Would anybody like to sort of guess, raise your hand on whether you think salaries are higher in Spain? I see shaking of heads, but no, so nobody thinks salaries are higher in Spain. And in the U.S., salaries are higher in the U.S.? Okay, I see nods. Okay, and a few hands. Well, you guys are so smart. You guys are right. Couldn't fool you. I took some samples out of the mental health system, and I couldn't find a nurse assistant salary to quote, but a nurse assistant is over $22,000 in Spain. For nurses, $60,000. Clinical psychologist in Spain makes $49,690. Clinical psychologist here, median, is $79,570. And then fourth-year residents make $45,240 versus fourth-year residents here, the mean is $52,000. Now, one thing about the Spanish residents is they actually get paid for call, hint, hint. And so the more call they do, the more they get paid. So this is about average based on including call and getting paid for call. So now I'd like to take another poll. You guys have been great. Thanks for bearing with me on this. But anybody want to take a guess on what an entry-level attending might make in Spain? Just throw it out there. You saw what the residents make. This is somebody just out of training. Anybody want to throw out some numbers? 60,000. Anybody else? 40, 100, 60,000, 40, 100? Okay. Anybody $1? Okay. $49,690 is what an entry-level attending makes in Spain. A practicing psychiatrist here, and this is an attending period. There's no change depending on your specialty if you're working in the public health system. It actually depends on the number of years you're working. So practicing psychiatrist makes $134,000 as a median. A medical director, Dr. Heron, $64,290. A medical director in the United States, median, this is across the board, not just for psychiatry or anything, $248,350. And I threw in the CEO of United Health Group at $124,800,000 just in 2005, and I'm probably misquoting this, but it was about I think $5 million in 3 years. So yeah, it's a lot of money. Another thing, if you're looking at salaries, you also have to look at costs. What are charges? What are the charges for pharmaceuticals and for hospitals? Well, in Spain, to get a hospital room in Spain in the public health system, where this is including nursing charges, food, the room, everything except for medications and physician charges, it's $260 a night. Less than some hotels, right? You get that same room, same services here in the U.S., it's $1,091.38 per night. That's without medications, any procedures, nothing. Lamictal, a medication that we often use here in psychiatry, 200 milligram tab, 30 of them, out of pocket, retail, just paying right there without any kind of Social Security help, $30.12. Lamictal, 200 milligrams for 60 tabs. I know it's double, but it's $389.99 here. So big, big differences. And just to round it out, and again, lots and lots of numbers, I hope you guys are sticking with me on this. The vast majority of expenditures are on inpatient and outpatient services. It makes sense for ambulatory care that there would be most because most people use outpatient services, but it's important to know that a big chunk of that, 31.4%, is actually for inpatient services, which is incredibly expensive for our country. And pharmaceuticals, 19.8%. Okay, so numbers, 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 systems. Now let's look at what's wrong with each of these systems. Again, we want to be really unbiased here. So in general, in Spain, there was lots of pride and satisfaction in their system. You had those that were on either extreme, where some people thought that their health system was the best thing since sliced bread and nothing can beat it. And then you have the other folks that actually wanted a system closer to what US has. But in general, they were happy with it. After I asked more specific questions of the medical providers there, I got some great answers, actually. They feel like their system is really good for severe illness, but it's less helpful if you have a minor ailment. And an example of this is there was a resident I was working with, super, super in shape, ran every single day. She actually hurt her knee. And after she hurt her knee, she went to an orthopedist. The orthopedist said, well, the reality is you need to get an MRI. Well, first of all, it took 2 months for her to get that appointment with the orthopedist. Secondly, he said, well, you need an MRI. We'll schedule you 6 months from now. So a total of 8 months where she was having, this problem with the knee and had no imaging whatsoever. Another important part is that there's less private industry in Spain. And for that reason, there's less research funding in Spain. And Dr. Manolo Cuesta is a very well-known researcher in Spain and actually in the US as well for schizophrenia. And one of the things he talked about, and as well as Dr. Sochi and my attending at the private hospital, was that they have this dream of being able to be a researcher, and be able to make money as a researcher. Well, the reality is that in Spain, you're a clinician. If you do research, the research is on your own time, and you have to find funding on your own. And so that was a big, big concern for a lot of the attendings out there. How's it different? It's not different for you guys, but there are some people at like UCLA that do nothing but research, maybe see like a patient a week. So the other thing is there are very short patient visits. So the public health system hours are from 8 a.m. to 3 p.m. It's set, 8 a.m. to 3 p.m. And within that time, you see many, many patients. The average family practice or general visit, 5 to 10 minutes. Psychiatric is 10 to 15 minutes. And that's straight through. Okay, you got like breakfast, right? There's always a little break. at around 9:30, where they have like, some bread. But throughout that time, you're seeing patient after patient after patient. And they don't take lunch until 3 in Spain, so that's nonstop throughout the day. Also, if you're a physician, you work where there's a position. So I had actually one of the fellows who's from the Canary Islands, and she wanted to go back home. She applied for a public health position, which is actually better paying. Believe it or not, those numbers were public system numbers for the salaries, better paying than private sector. And she wanted to work in the Canary Islands. She was rejected for a position in the Canary Islands because you have to wait till there's a slot open. So she's going to have to work in the private sector. The other thing is, if let's say she got a slot, she wouldn't necessarily work, in a major city. She could be out on one of the islands that are super small, very unpopulated, and they tell you where to work. You can't just say, oh, I'm going to work in this city and find a job, like you can here. Also, there are fewer medications available. An example is for ADHD, the only stimulant that they had available for treatment of ADHD was methylphenidate. They had different preparations, but the only stimulant you had to choose from was methylphenidate. Next, the government is involved in all aspects of what you do. And they're involved in training, they're involved in, it's endless, they're involved. So you take that as a problem or not, but it's a reality. There are the high taxes that we talked about. And there's also a triage of health treatments. And I'm actually going to talk a little bit more about that in a bit. But this means that, again, if there's an emergent issue, that person gets to get that MRI before the person who has the hurt knee. If you're elderly and you need, you're 95 years old, you get into an accident, you're not getting the $1 million workup in Spain. That 25-year-old who got into an accident will get that, but not the 95-year-old. So here's a little cartoon about healthcare, about universal healthcare. I'm happy to inform you folks that you have aged out of the universal healthcare and now qualify for your 10-day twilight holiday cruise, culminating in a lovely burial at sea. Okay. But seriously, I'd like to give you an example of one of the problems. I actually saw this kid in the private hospital where I was working, and his name is Raj. He's a 15-year-old male who was diagnosed with Ewing sarcoma. And he came into the clinic because his pediatric oncologist started to notice that he was pretty depressed. And this kid was. He was actually a UK citizen and had been receiving treatment at the renowned University College London Hospital for recurring lesions after failing first round of chemotherapy. So he's getting lesions in his skull. He presented to the University of Navarra, came all the way to Spain in order to try to get that second round of chemotherapy. Because while in London, he was actually refused the second round and told that he needed to get palliative radiation therapy to the lesions that they found in his skull. Sad, but let's look at why. Raj actually only had a 5% 5-year survival rate after failing first round of chemotherapy. And so they figured it was heroic measures to try to give him another round of chemotherapy. And there's also consideration of his quality of life. Would he be able to make it through all of that? And so he was denied that. So he came down to Spain, and they offered him second round of chemotherapy as well as stem cell therapy. And even after all of that, and after he's probably still getting treatments, he only has a 15% 5-year survival rate. So he's actually getting treatments now, and his parents are paying out of pocket for this for him. But Spain's not the only one with problems. We have a lot. We in the U.S. have quite a few problems with our health system. Generally speaking, Americans are happy with the quality of health care that they get, generally speaking, but they are really dissatisfied with how much it costs to get health care here. In 2000, for the presidential election, the number one healthcare issue for voters was how to appropriate funds for the uninsured. So we really want people to get health care. We want people to not be left out of being able to receive treatment. And we want it for everyone. However, we also still want to maintain autonomy. We still want to be able to dictate where we go for our treatments, how much treatment we receive, how fast it happens. We still want all of those things, and that's a difficult thing to put together. So per a Gallup Health survey in November of 2008, more and more Americans really are having to decide between their medical treatments and paying for necessities like electricity or food. And this is a 2006 survey that showed that 48.1% of adults were untreated for mental health disorders because the cost was prohibitive here in the U.S. So we got a cartoon for the U.S. We got to be even here, right? So we have here the hospitals, the uninsured, the insured, and at least the hospitals and the insured are somewhat covered, right? But then we have our crisis is showing. So poor uninsured with a bedpan. Okay, so here's an example of a case that I had here. This is a patient I have in the telemed clinic here. Her name is Margarita. She's a 45-year-old female with a history of schizoaffective disorder who is being seen for medication management. And this telemed clinic that I'm working for specifically receives a grant specifically for treating under and uninsured people. She'd actually been stable for nearly a year on Thorazine until 3 months ago when the price of the medication increased after the pharmacy changed generic companies, went to $181 for her 30-day supply. And so it was at this time that Margarita really had to decide whether or not to pay for her medications or pay for electricity and things like that in her home. Luckily, we were able to help her, and so is her father. But that's actually not an uncommon story here in the U.S. Okay. So we've done all of this. Now we're at the end. Take a deep breath, for me maybe. The impact of culture on health delivery. And again, I think it's really important to look at culture, because culture really impacts how we set up our system, how we view our systems. So let's start with the U.S. And I know I'm going to get slack for the Cubs, but bear with it. At least Dr. Heron's not here. Americans are generally satisfied with their health care, but there is a fear that that care is insecure because of the costs. There's also a lack of trust in general of the government. And an example of this is that 55% of people who were polled, and this was a survey done by NPR and Harvard School of Public Health in 2008, said that they did want medical experts to be involved in reforming our current healthcare system. However, when you added the word that these experts were named by the government, that percentage dropped to 41%. So there's distrust. In addition, Americans don't want to pay a whole lot for their health insurance. In that same study, 6% were willing to pay less than $400 a month for their health care insurance. 29% were willing to pay less than $200 a month. But the vast majority of those polled in this survey said that they would not pay any more than $100 a month for health care. So it's incongruent, right? Cultural impact Spain. So the reality is they really do consider that their actions impact everybody because they know that they have to wait a long time. The reality is that that just means that there are other people that need to receive services before they do. And they understand that there are limitations of the system. That being said, they also have private health insurance. So there is a part of the culture that wants what they want when they want it. So then those who can't afford to purchase private health insurance do, and they can get faster care. High taxes are the reality. They complained, but it is the reality. And also they allow autonomy for certain states. And this is where I'll get to talking about Navarra and the Basque Country. One thing I learned is you don't talk about the Basque separatist movement in Spain, so I won't go political, but the reality is that Navarra is the province right next to the Basque Country. And because of their efforts towards being much more autonomous from the Spanish government, they actually have more autonomy in their taxation system, in their healthcare system. And it's for that reason there are those differences for those areas. And I got a lot of flack for putting Barcelona up there. When I was in Spain, they're big into Madrid, but they just won the championship, I heard, so the club championship, so pretty good. And then that's Sevilla over there during Semana Santa, and then this is, I can't remember the name of the castle, but it's one of the castles that is that are in Navarra. So, done. And I'll open up for questions from both UMC and UPH, because I was told to make sure to recognize you guys wherever you are. So, questions? Dr. Trimble.
One question, one comment. The comment was that I traveled to Spain some and had a number of friends there. There's sort of an underground economy that goes on there. And they do have higher taxes, but they don't pay their taxes. So, so that's one thing that goes on. The other thing is, what about the malpractice situation? What's the legal aspects?
It's not an issue, actually. Another two things that are important to note there, and I didn't put it in my talk, is one, your education is free. So it's not like these folks are coming out of medical school or out of residency with tons and tons of debt like we are. They don't have to worry about that. All of their education is free. You can go to private schools if you choose and take out loans for that, but the vast majority don't do that. Malpractice is not an issue there. They don't worry about it. There's still always the potential for a lawsuit, but the reality is they do not think about it at all because it just doesn't happen, which is another cultural aspect that is a reality here, is there's lots of fear of lawsuits, but in Spain there just isn't. And I think I've seen some treading some water out there as far as some of the activities, so they really don't worry about it. Yeah, Dr. Gibbert.
A couple of questions, a couple of comments. Thank you very much for this fascinating talk. Question is, the psychiatrists, are they then all consultants since you have to go to a PCP first?
I guess more or less. Once you get into a psychiatrist, they are your psychiatrist. It's not like for each problem you have to be referred back. It's just that you can't just walk up to a psychiatry clinic and get in that way, unless it's a private clinic.
So everybody has to be referred.
Right.
And if you wanted to practice some form of psychotherapy or technique or whatever, you could do that outside of the system.
Yeah. The vast majority of people who work in the public system, after they're done at 3 p.m., they have their own private or group practice in which they treat people, and they can do therapy there. But honestly, it's not even really a part of the education. So they don't really get a lot of education in therapy either.
And to throw in a couple of comments, one is if anybody's interested in looking at a really interesting detailed article, this past weekend in the New York Times, there's a wonderful journalistic article on the Dutch system, which has, you can see it online. Their tax rate in the Netherlands is 52%, right? So dentistry is included. And the other thing is that I come from, of course, a national healthcare system in Canada. And it is the only country in the world that doesn't allow any private system. Now, it's going broke. And the government now, there are private clinics opening here and there in major cities, particularly in Alberta where there's extra money. But those clinics are illegal, and the government is pretending they're not existing at the moment because it's helping the government to pay. So the government is going broke, and family doctors have 4 minutes on average to see a patient in Canada because there's no private help. And yet Canadians see themselves as Canadian based on their national health care. If there was no national health care, there would be no Canadians, because that's how they identify themselves. So it's so much part of the culture, and yet there's so much naivety to it. And of course, like you were saying, in Spain, cancer patients wait months to get an MRI. And I was astounded coming here and working in the emergency room when people just snap their fingers, okay, we want an MRI here, an MRI there. It's like, it's absolutely amazing. However, there's this huge cost to be paid here. So I think you really clearly looked at both sides of the equation and how it's very difficult, but I would never want a system that doesn't have both.
Dr. Lane?
Great talk, by the way. Where does Spain stand in relation to parity for mental health services? Clearly, in this country, you know, we get carve-outs for psychiatry. What about in Spain?
Well, when you say parity, can you clarify what you mean?
Well, I guess appropriate funding for psychiatric services on a par with, you know, general medical services.
It really depends on each province, and actually that was one of the articles that I read, was that, you know, because there's such variation between each province, that's why a lot of people, I mean, just because you live in Andalusia or in you know, Sevilla doesn't mean you can't go to Pamplona to get your care. So that's what tends to happen, is the places that have the better funding for that area folks will travel. I mean, folks were traveling every month across the country, literally, to come to both the public system as well as the private system. Mostly the private system, though. So parity, I think, is kind of difficult to spell out for you. I apologize. I think in Navarra that it's very, very equal, but yeah.
The equivalent of carve-outs and ability to provide mental health services in the same way that we experience that here in Arizona.
No, I didn't. And it seemed to be that people felt very comfortable going to mental health, and it didn't seem like, there were too few services. I was actually pretty impressed by the services that were provided. But I was in Navarra. I didn't see any place else, though. So, Dr. Kumar.
Yeah, you mentioned that they have only one stimulant. Do they have child psychiatrists or child psychiatry there?
They will very soon. Actually, child psychiatry is not a recognized specialty, but actually this year they have decided that they should do that because they were having general psychiatrists treat kids that didn't actually have any training in child psychiatry. They would get 3 months of child psychiatry training in their full 4 years, and they would be treating children regularly. So they're now changing that. But all these folks that go to fellowships, because there are fellowships, they're not recognized as child psychiatrists. Not this time. Discussion. What about Kino? Is there anybody Kino? Where is Kino?
Yes, we're here. Can you hear us?
I can hear you. Any questions from over there?
Do you know if there's a difference in? Oh, sorry, there's an echo. It's hard for me to.
It's pretty loud.
If there's a difference in mortality rates between the U.S., given that the U.S. system is more aggressive than.
Okay, I didn't fully hear all of that. What's more aggressive in the U.S.?
If the U.S. system is, the U.S. medical system is more aggressive in treating patients like treating cancer sooner or having appointments sooner.
Yeah, I think preventative. Sorry.
Does that have an effect on the overall mortality rate there?
You know, it's actually interesting. I did look at the mortality rate of both countries, and there's not a vast difference between the two countries. But again, if you're looking at mortality rates, it's not looking at how many people are living. It's just looking at the age, the length of age. So I didn't see how many people are living to old age, but I did see that the average age is in the 70s, which is the same for the U.S. But it is true that they treat, in the public system, things like cancer a little less aggressively than they do here in the U.S. But there are also private institutions that are willing to do everything. I mean, you heard stem cell therapy at the private hospital where I was working. So they're willing to do it if you can pay it. Whereas here in the U.S., we'll pretty much do it regardless of your ability to pay. Anything else? Okay, if you guys want to stay, I know it's a long time, but if you wanted to stay, I was going to show some pictures of my trip. Oh, and also, I'm sorry, I really need to thank folks. I really want to thank the folks that I worked with in Spain, Dr. Sotillo, Dr. Cuesta, Dr. Figueroa is the fellow I worked with, Dr. Heron. Maria was an angel in helping me organize all this because it was a bureaucratic nightmare. Dr. Mishashek, Dr. Robert Adaran for pimping out my presentation, and the Residency Education Committee for, I'm seriously grateful that you guys allowed me to have this really amazing experience for 2 months in Spain. So, thank you.